Glomerular nephritis is inflammation of the glomeruli. So this is inflammation of the filtering part of the kidney. So kidney filtering will be affected. Depending on how bad this is, we could see some possible permanent scarring on the kidney, which will lead to more chronic problems. Glomerular nephritis could be acute or chronic. With acute glomerular nephritis, it is a temporary reversible problem. An example of this is acute post-strep glomerular nephritis. And this is when your patient develops glomerular nephritis 1 to 2 weeks after having strep throat. So what happens with this is the antibodies from the strep throat actually get lodged inside of the glomeruli and cause damage. However, the reason that they do this is unknown, but what we do know is the antibodies get stuck in the glomeruli and cause damage. So we need to think about what happens when the filtering part of our kidney is damaged. Well, with that, our GFR is going to decrease. So we'll see a decreased GFR because the glomeruli are damaged, are inflamed. And because the GFR is low, we'll see an increase in the BUN and the creatinine. So that's due to the decreased GFR because we are holding on to toxins. We also typically see oliguria, and that is because the kidneys are filtering slowly and not producing urine. We see generalized edema and hypertension because the patient is holding on to fluid. They're not filtering and excreting it out. They're holding on to that. So we see a buildup in the tissues and we see a buildup in the vascular space. And then we see hematuria and proteinuria because the filtering part of the kidney is damaged. So we're not filtering like we should. We have damage to the kidney tissue. All of that shows up in the urine. So our treatments are going to be antibiotics as needed, especially if the strep was not fully treated. Have the patient rest, do sodium and fluid restriction since we're already dealing with an increase in fluid. We can use diuretics to help with that fluid volume excess, and we like ACE inhibitors. Remember, ACE inhibitors were those medicines that ended in pril. They treat hypertension, and they also decrease protein spilling over into the urine. So for here, it can help us in 2 ways. It can help us with the hypertension and the proteinuria. We also want to do strict INOs, daily weights, and if our patient is on antibiotics, we want to make sure we educate them to take the full course because of antibiotic resistance. With chronic glomerular nephritis, we see all of the same issues as we did with acute glomerular nephritis. So make sure to go back to that slide. The only difference is now we have permanent damage to the kidneys. This is now a chronic problem. So because it's a chronic problem, it happens slowly over time. Can this problem lead to end-stage renal disease? Yes, it can. So we may need to prep our patients for dialysis or a transplant. So our common causes are going to be things like toxic drugs, viral infections like hepatitis, and immune disorders like lupus. So we need to make sure we're educating our patients to seek early treatment for infections in these conditions. Our treatment is going to be symptom management. Remember, this is chronic. We'll never fix it completely. And for diet changes, these diet changes are going to be permanent diet changes. Your patient will be on a permanent fluid restriction because it's always going to be very possible for this patient to go into fluid volume overload. With nephrotic syndrome, the glomerulus is too permeable. So we have a problem with filtering. And what we have a problem with is losing protein in the urine. So think big holes in the filter and losing protein. So with nephrotic syndrome, your patient will have low plasma albumin levels. Remember, albumin is a protein, and those low plasma albumin levels will lead to edema. your normal albumin levels are going to be 3.4 to 5.4. The reason we see all of that edema is because of the low levels of albumin in the vascular space. To keep fluid in the vascular space, you need to have protein in the vascular space. So with these low albumin levels in the vascular space, you'll start to see fluid shift out of the vascular space and shift into the tissues, and that is where we start to get the edema from. So with nephrotic syndrome, we see tons of edema, and if your patient has total body edema, that is called anasarca. So one of the ways we treat nephrotic syndrome is by giving steroids to shrink those big holes that we talked about so we stop losing the protein. One of the side effects of steroids is fluid retention. So if we're retaining a bunch of fluid on top of this, we can also see some hypertension. Hyperlipidemia is also a complication of nephrotic syndrome because the liver tries to help out the kidneys. The liver creates albumin. So when the liver notices that there's low albumin levels, the liver can help and create albumin. However, when the liver creates albumin, it also creates cholesterol and triglycerides. So that's where we get the hyperlipidemia from. Foamy urine is also a manifestation, and that comes from the protein and the fat spilling over into the urine. To treat nephrotic syndrome, we'll do steroids to decrease the inflammation and shrink the holes. We'll have this patient increase protein. So again, this is an exception to our normal kidney problem rules. We normally restrict protein, but with nephrotic syndrome, we want to increase protein because your patient is losing so much protein in the urine. We can also treat this with diuretics to help our fluid volume. We want to limit sodium because we're already keeping a bunch of extra fluid. And then we want to give a lipid-lowering drugs to help with the high cholesterol, which was the byproduct from the liver trying to help out and create that albumin. ACE inhibitors can also help here for the hypertension, as well as decreasing the protein that's spilling over into the urine. Remember, ACE inhibitor were the drugs that end in pril. And then with these patients, we want to do strict INOs and daily weights. With renal cancer, we're going to see this more commonly in men, and our biggest risk factors are going to be smoking and obesity. Renal cancer is typically asymptomatic in the early stages. Once it is caught, it's usually not very responsive to chemo or radiation. So typically the first line of treatment is going to be a partial or a total nephrectomy. So that is when they either remove part of the kidney or they actually remove the entire kidney. They can also do cryoablation where they freeze off tissue, so they freeze off the tumor. And then we can also try immunotherapy.